Excellent. So really, while we're here together right now, and not just me as a person alone, but as the collaborative. So I don't know if that's, yeah, they're up there. So really what the Cancer and Mental Health Collaborative is, it is a group of different organizations with a shared commitment to advancing equity in cancer research and cancer care for people affected by mental illness and their caregivers. That is our mission. How do we achieve that mission? Part of it is through the 3 factors, right, that Sherry and I talked about at our first meeting. So big picture, how do we improve things for people who are coping with cancer and mental illness, whether we be as patients or family members or caregivers or clinicians or researchers? So I think we talked about research, we talked about clinical care, and we talked about advocacy. So I thought those might be 3 kind of topics to organize our discussion, and my hope was that together with you, if you have thoughts on things you've thought about today that you really want to learn more about, or feel like it's time for us to take action on, this is your chance to make sure that we hear your words. And so you've written some of them down in the breakout sessions, but I want to actually have a dialogue now about what your priorities are for you. So I don't know, Sherry, if you want to reflect on any of your thoughts so far on priorities.
Well, I just came from the Children and Adolescent Workshop, and one of the things that I heard that was moving to me was that when children and adolescents with cancer have also concomitant mental health needs, that the cancer care is covered often, but the behavioral health needs are not. And I found that outrageous. I just found that outrageous.
Absolutely. So
an example of something that requires action.
So for me, I hear that as parity, the lack of parity of cancer and mental health care and the need for advocacy and change to cover services equally. Probably it's more than that too.
Well, I think a related point is just also the levels of reimbursement that are paid for these services. And I think that, one of the big elephants in the room is just the lack of providers, behavioral health specialists, and, burnout and the challenge of working this population contributes, but also just low payments. And so how do we kind of put together sort of the evidence for policy that's needed to kind of address all these major issues?
I think that's especially true for children. I can tell you that as someone who's the community liaison trying to find a family, a behavioral health specialist who can work with children is really, really difficult. These are providers that are often full. They may not take insurance, or they may take a limited amount of insurances, and it really limits those families who may want their child to have, behavioral health services. It limits their ability to connect with that piece of their child's health.
I think that's true, and I think is also a real limitation when people have any sort of complex needs, and whether that be poverty, social determinants, homelessness, psychotic disorder, acute medical illness. Well, gosh, that's a hard provider to find. So when we actually think about access, it's not just that we can find someone in a directory. It's that it's a person that person can get to, and they can actually have the capacity to care for them clinically. So access is a lot of things. So more actually capacity to actually care for people with the needs that they have. Thank you. That's very nice. You guys don't want to hear me all day. I know I'm compelling, but.
Kelly, right here.
I think I was just going to echo the same concern about accessibility from good mental health services for adults. I mean, I work in central Massachusetts, and I can't tell you, how many people could benefit from psychiatry that, maybe in 12 weeks. You look even for people who have commercial insurance who can't access the benefit. People aren't accepting new patients. There's 12 weeks before they can get even an initial intake appointment. It's horrible. It's horrible. And the more complicated your care is, if you have comorbid addiction, mental health. I mean, it's a package deal. It's very hard to deal with, and very hard to find people effective service.
Right, we heard about Mass Health instituting a loan forgiveness program, and I wonder if a statewide loan forgiveness program isn't something to look into.
And I mean, I would actually, absolutely, and I would echo that, actually that frame of why are we always thinking about like getting that patient to this hard thing that's hard to get to. That's the same thing with research, that we need to just change the paradigm so that we can actually make it easier. It's on us to change the system, you know, in terms of how we do clinical care, but also in terms of how we do research, so that the results that we find are representative of all of our needs. And so that's I think, really important for all of us to think about how to meet people where they are in both care and research.
Can I see a show of hands of our community health workers, our community-based caregivers? I see some of you up there.
Yeah, there you are. Talk.
All right.
Yeah.
All right. I think that this is one of the things that I heard yesterday and again today through Berilyn speaking yesterday, Gary, and Kriya, is just the need for training and support for this group of caregivers, and to be seen as a real group of caregivers, not just as sort of not on the level as family caregivers, but as Gary said, we are their family. So that's one of the things that I really hope to see us working towards is whether it's peer supervision or clinical supervision or something that provides support for our community-based caregivers.
You guys think about that. You agree? And how'd you change it? I know your names, yes. Go ahead. Yes, Berlin. You have a very resonant voice. I think we can hear you.
I can use the steps. I need the steps.
The first thing I want to say is going back to communication, because we know about releases and all that, but I think one important point that is always a barrier to communication is they always bring the question of HIPAA. So we don't know if it's that generally HIPAA regulations are not understood clearly, or they are being misinterpreted, or we really don't know. But I think just getting that support to train clinicians in the community and frontline staff and other providers on interpreting HIPAA the way it was written and it's supposed to be interpreted is really important in fostering communication, because I think we get frustrated most times because we don't get that information that we need for care continuity and for a warm handoff. All that doesn't fall in place nicely because somehow HIPAA comes in.
Absolutely. That's so important. And HIPAA is almost always misunderstood in my experience. When you are taking care of someone clinically, you know what HIPAA's for? To facilitate communication. If someone's in the hospital, we can find a way to communicate more effectively. So that's absolutely an important point for next year. To bring up hospitalizations, gosh, I still feel there are not enough beds for people with complex medical and psychiatric needs, and not enough capacity for the people who are going to take care of them there. So I can't end the conversation without throwing that out there. From the whole spectrum, from the point of people who are not accessing cancer screening because they need to be in a facility where they can do their prep, to the point of someone dying and needing a dignified place to die. Please, of course, Dan.
I just want to add something about HIPAA. One of the problems within DMH is that the privacy requirements in DMH regulations have actually been stricter than HIPAA. DMH staff, in spite of HIPAA, have had to get a signed release from a patient or guardian to talk to caregivers that HIPAA would permit contact with without a release. That's actually changing. It had to change as part of the new system restructuring because the DMH services had to come in alignment with Mass Health and behavioral health community partners. So there is a privacy, that higher privacy standard is now being changed with this new system.
That's great to hear.
Kind of piggybacking on the earlier comment about community mental health and all the wonderful resources we already have already. I've heard a lot of great things about places like Freedman Trail, Lindemann McGinnis House, and I love to see more occupational therapists mobilized in those clinics because occupational therapists are a unique profession that can provide holistic care, and that's what we've been doing. We focus on both mental health and physical health, and I feel like we could be that bridge between group home managers and caretakers and the psychiatrists and physicians.
Wonderful to hear. Thank you so much for saying that. Go ahead, just talk loud and proud, Berlin.
I just wanted to go back on the science part. So does it mean that when, for example, when we send patients out to be evaluated in hospitals and eventually get hospitalized, we usually have the assigned releases in the package we send out with them. So the ones that are signed at the group homes, they are not valid in those institutions. DMH is stricter on those. They have to sign DMH releases on top of those ones.
That situation wouldn't have anything to do with DMH. The hospital would do what it does, but if the releases were a provider's release, like Vinfen or North Suffolk or something like that, that's separate from the DMH release, and whether the hospital would accept those releases or have to get their own, I think that's something that each individual hospital would determine.
I think the DMH policy part was just like an FYI. If you think that's bad, DMH is stricter. It didn't have anything really to do with what you asked. Well, if you think that's hard, DMH is more difficult.
I guess my question now is, so work around policy to ensure that there is some form of a common release that can be used.
So I think that's a really good point. So I think we can kind of put that on the agenda, improving communication and decreasing barriers to privacy. I also want to make sure we kind of hit some other topics. We've only got a couple more minutes before we go to the next thing. No?
Got a couple of
Yes, go ahead.
I like to push for the importance of providing culturally and linguistically. Oh, do I need the mic? I think I'm low.
Culturally and linguistically appropriate.
Yes, and by working with community-based organizations, so we can bridge the link between the community and the clinical provider.
Yes, and I think that the culture of community mental health is also related to that. I can't see everybody, so you don't have to be aggressive and let me know where you are. Yep. Go ahead.
Yes, I have one small question. Thanks for the great symposium yesterday and today. We often meet friends or relatives who are sick with mental illness. So you can't call 911, but we still want to be very quickly responsive. For example, a patient in a skilled nursing facility has mental illness, and her mental illness was never addressed. And we advocate to the nurses and doctors, and they never get the mental health care person to like a provider come to say, or how quickly we can get a response. Say we make a phone call there within how much time you can have people actually go to see her.
I think your comments bring up a lot of important issues. So I think that just to try to extract something from that, I think that not only communication among clinicians, but also opening up barriers for families to get information and have that happen rapidly, right? For us to really be part of the same team.
Did you?
Sure. As I listen to Dr. Chabner, and this is in the area of advocacy, all of these groups do such wonderful things and the research and so forth. But to increase greater awareness in the broader community, to enhance your chance for funding and so forth, I'm wondering if there's one committee or group that can be pulled from all of these that could force the political actions that are required for Massachusetts as well as federally. Because I'm sure everybody's doing something. but it might not be as coordinated and as powerful as it could be if you had it all in one bucket. Just a thought.
So I think that part of the goal of this symposium is to really gauge the community's interest in working on these issues, to test out the partnerships that have come together to put on this symposium, and to look at next steps that may lead to something like that. So I really am grateful for that suggestion. Are we ready for the walk?
The walk?
Can I plug the walk?
Absolutely.
So one next step I want to plug is you have in your packets a flyer for next Saturday. NAMI Mass has their 15th annual walk, and it's a 5K, and it's a really exciting event. More than 5,000 people come out. It's our major fundraiser. It funds all of our education programs, our support programs, and our advocacy. And it is also the biggest stigma buster around. So we hope you'll come, we hope you'll bring your friends, and we hope you'll contribute. Okay?
Absolutely. Thank you. I'm going to just briefly, so we'll keep the conversation going around lunch, but I just wanted to very specifically say, this is the beginning, or maybe it's the middle, because you were there last year, and now we are in the middle. This is a collaborative. That means that we're going to be calling on you to take action. So if you don't want, an email from me quarterly, you can let me know. Otherwise, you will get one, and we will think about the ways in which we can collaborate to do research in the community. That means I might be saying, hey, what about doing a research study in your organization? What do you think about that? It might be saying, hey, I think we need to go and advocate for this. Do you want to come speak with me? Or hopefully it's me saying, what would you like to do? What would be important for you? And you telling me that and us that. So we really want to hear that, and I just wanted to emphasize that the hope is that we actually do put together research, advocacy, and clinical projects, but particularly patient-centered research, to keep going with this collaborative. The patient-centered PCORI Organization for Research, they've funded us to come together as a collaborative to have future research projects, to advance equity. So that's on us to take this energy here and translate that into projects that can be funded and effective advocacy. So I'll end with that, and we'll go have some lunch together. I just want to thank all of you for being here and participating.